Okay, I think we're ready to start part 2 of this excellent afternoon session, thanks to a team effort of really everybody coming up with ideas how to make captioning work. The program will be slightly changed. So we're starting actually off with Dr. Francis Creighton, who is an assistant professor at Johns Hopkins. He is an ENT and skull-based surgeon. He has focused his interest in patients with vestibular schwannomas and hearing loss and is working very closely with the NF clinic. He will share with us today his surgical perspectives on the management of patients with vestibular schwannomas, and we are very excited to have him here today. After his talk, Dr. Blakeley will give us some insight on the medical management of these tumors. So thank you.
Great, thank you. Sorry for all the, hey, oh, we're good? Captioning working? Good. I'm Francis Creighton. I am at Johns Hopkins, and I'm trained in ENT, and I spend most of my life trying to help people hear better. So obviously NF2 is very near to my heart, and I work with Dr. Blakeley and our center there very frequently. Do I have a way to go to the next slide? Let's see if we can. All right, hey, we're doing good now. I will not be talking about anything off-label here, and I have no other financial disclosures. Here's kind of what I would like to talk about, just to give a brief background of how we hear. I think that's important to understand why and what we do in terms of a surgical standpoint from hearing. And then talk a little bit about why NF2 specifically and why acoustic neuromas cause, or vestibular schwannomas cause, hearing loss. I think that we've learned a lot about that over the last 10 years, and that's important for how we go about treating. Most of the time I give a talk on hearing, I usually start with this. It's a quote from Carl Jung, and I think it's important because it is really hard not to be able to talk to the people you love and not to be able to hear the people you love. And I think it's a very important thing for people. We good? So very briefly, ear anatomy. You have 3 parts of your ear. You have an external ear, which is the part outside that you see, and your ear canal. That functions to funnel acoustic energy down your ear canal and towards your eardrum. And you have a middle ear, which is made of your eardrum and 3 bones of hearing. The whole point of your middle ear is to take acoustic energy and turn it into mechanical energy. And that mechanical energy goes through 3 bones. And the last one is called the stapes. And just to give you an idea of why people who do what I do are a little bit OCD and neurotic, is that all 3 of those bones would fit inside a dime. So it's just very tiny, delicate stuff we're talking about. The inner ear is made of the cochlea and the labyrinth. So both the balance and the hearing side of this. And I think that a talk on the balance problems with NF2 is an entirely different scenario, and one that is equally important, but I won't talk too much about that today. And what the inner ear does, and does very well, can I go to the next slide? Is that it takes the mechanical energy from those bones of hearing and it converts it to a fluid wave. And that fluid wave travels down 3 chambers in the inner ear, and it causes that part of the inner ear to activate. And when it activates, it sends an electrical signal to your brain. And that's how you hear. What's very cool about that system, if I can go to the next slide, is, sorry, I'm not sure why that quite skipped out, but your inner ear is what we call tonotopically mapped, which means that your inner ear, the cochlea is a snail shell, and it has very specific areas within it that pick up very specific frequencies. And that is why the cochlear implant has been the greatest invention in biomedical engineering in terms of restoring a sense, Whereas in the retina and other senses, we have a much harder time doing it because we have a cheat sheet. We know where in the cochlea certain things are going to stimulate to match up with specific frequencies of sound. And that's very important as we kind of go in and talk about cochlear implants and AVIs. I think this will be recorded. If you ever want to learn more about hearing, this is a YouTube video. And if you watch this, you will know more than most of my second-year residents. It is a very good animation about how it works. But tonotopic mapping is really very, very, very important. So moving on, what happens after you get to the inner ear? Well, you go down your 8th cranial nerve, and then there are several ascending pathways in the brain. The first being the cochlear nucleus, which is on the brainstem right about where the 7th and 8th cranial nerves come out. And the problem that we have with NF2 is that the tumor happens to sit right there. And so it is a problem not only for balance, but specifically for hearing. And we have, in the past, always thought that acoustic neuromas cause hearing loss because of compression, because they push on the nerve. And while that probably plays somewhat of a role, over the last 10 to 15 years, we've really appreciated that that's not all of it. I showed this image. This is a patient of mine who actually did not have NF2, but had a 6-centimeter tumor and had almost perfect hearing. And I can show you plenty of images of patients who have 4 to 5 millimeter tumors and have total deafness. It's not all about size. And so what we have learned, and the slide on the left is actually a nice study from 2012, where they looked at basically hearing and tumor size. And you can see that there's really not much of a correlation there. A lot of people have big tumors and have good hearing, and a lot of people have small tumors and have poor hearing. So what else is going on? We think that it's a combination of increase in protein inside the inner ear. And we think that happens for a few reasons. One is that these tumors actually block the outflow of CSF from the inner ear. And so proteins that normally are there, that normally can get out into the rest of the CSF space, now can't. And then we also think that the tumor itself secretes proteins, specifically some immunoglobulins. And there's a really nice study from the Harvard group, although Tina Stankovic's now at Stanford, showing that TNF alpha, if you actually take the serum of people who have had this done and then from the tumor and you actually put it into a mouse model, you actually will cause hearing loss just with some of these genes. And so we think that it's a combination of these two things. So it's not just about compression. So the other thing that I think everyone in this room knows is that it doesn't just cause a loss of how loud or soft sound comes in. More importantly, unlike with just regular age-related hearing loss, it causes a loss of your ability to understand sound. And so the vast majority of patients that I see in my practice who have age-related hearing loss, hearing aids work great for because they have clear sound coming in, but it's just soft and they just need it cranked up. For patients with NF2, that is almost never the case. It is almost always that they have not only just lost some of the loudness of sound, but they've also lost a lot of the clarity of sound. And losing that clarity is what is so hard on patients because you can hear, but you can't understand. And so that's why hearing aids are sometimes, but not always, a great option for patients with NF2. So when I think of surgical options that can help or either help restore or help preserve hearing, these are kind of the options we have. This is what I have at my disposal. And I'll take a second just to say that I'm a surgeon and I'm very aware of the fact that if you're a hammer, everything looks like a nail. And so when I am not taking care of NF2 patients, I'm pretty pro-surgery. I generally think that I'm going to make someone better if I do a surgery. What I think is very important with NF2 is that that's not always the case. You know, outside of hanging out with my kids, operating is like my favorite thing to do in the world. And I am often trying to talk people out of surgery with NF2. And that's where I think having a really good relationship with someone like Dr. Blakeley, where you have a comprehensive NF2 center, is really important because most of the time I'm not doing something until she tells me to. Because if I can get away with not treating you for a period of time, it's usually better. It's when we run out of other options that these are things to consider. So first, middle fossa tumor removal. So there's a little bit of controversy here, but I don't think much. In patients who don't have NF2 and have small tumors, there are very good rates of preserving hearing doing a middle fossa tumor resection, or even in a retrosig resection. What a middle fossa means is just that instead of coming from behind, we're coming from above. We get really geeked out about it as surgeons, but at the end of the day, it's just approaching the tumor from a slightly different angle. And in non-NF2 patients, depending on the study in the group, you can say between 80 to 90% of patients will retain some amount of hearing. One of the things that's a little bit harder is it puts the facial nerve a little bit more at risk, not a ton. Even with smaller tumors, it is still not always possible to save hearing with a middle fossa. Even looking at some of the best groups in the country who do this, about 50% of their patients still experience some degree of hearing loss afterwards. And oftentimes they do experience some tumor recurrence afterwards. So it's not if, oh, hey, you get it out once, it's a perfect shot, you're never gonna have to deal with it. Sometimes it is. And for the right patient, this can be a good option. The problem is, as most of you know, it's rare for someone to come in with an F2 and just have a little itty bitty tumor and no hearing loss. It happens every now and then, but most of the time, by the time patients are getting to us, they have bilateral tumors and they're too big for this approach. But for the right patient, it is a reasonable thing to consider, but it's got to be for the right patient. Next is middle fossa IEC decompression. And so this is just a video of me decompressing the IEC, which is just this little thing. This kind of was hot like in the middle 2000s or, about 10, 15 years ago. And the idea was that, well, we can go in via the middle fossa, not take the tumor out, but just open up the little bitty canal called the internal auditory canal, which is where all these nerves run. And when we thought compression was the whole issue, we thought that's where the compression was happening. And so a lot of groups have looked at, well, not a lot, but about 5 have looked at, does this help? And the results are mixed. And the problem is that it's a little bit hard to judge the results with this. So if I do the surgery on you and you don't lose hearing over the next year, well, I feel really good about it. You may not have lost hearing if I didn't do surgery. And that's a really hard thing for us to predict. In general, it's a well-tolerated surgery. So I think it's not always, I'm not saying that I think it's a bad idea. It's just one to say, it's hard to say definitively how much it helps. There are a few studies that have shown people, particularly people who've had cochlear implants, actually get improvement in hearing after this, but it's pretty rare. What is nice about this is it's overall a fairly well-tolerated surgery. The risk of facial nerve weakness or worsening hearing immediately after surgery are pretty low. So it is definitely something you can consider, but it's not, we think about this pretty rarely. Usually if I'm between this and treating you with Bev or something like that, I think that's the better option. But for some patients, this can be a good option. For patients who have lost hearing on one side and still have some decent hearing on the other side, a bone anchor hearing aid can be helpful. It's a very simple surgical procedure. And instead of putting something in your inner ear, like a cochlear implant, or in your brain, like an auditory brainstem implant, it's a simple little post that we screw into your skull. And it is as simple as it sounds. There's a countersink drill, and then you drill it in after that. I could probably teach anyone here to do it in about 5 minutes. It's very simple, very low risk. It does not get sound into your bad side, but it can transmit sound from your bad side to your good side. And what that can help with is if someone's talking on your bad side, you can't hear them, well, now you can. It doesn't totally fix the problem of speech and noise where you walk into a crowded room and you have difficulty hearing, but it can help with it. What it's not going to help with is localization. And that's what, when patients lose hearing in one ear, they can hear a cell phone go off, but they have no idea where it is. It's because you're not getting sound into that ear, it's not going to help with that. The next, and I'll talk probably most about this because I think for a patient who's eligible, I think this is your best shot at getting hearing back. And so for a long time, we had difficulty implanting cochlear implants in patients with an F2 who had good hearing on one ear because the FDA insurance companies said you couldn't do it. And in 2019, that changed. And so there's been a large push in this. And while we've done this before at Hopkins, I think we're doing it a lot more now. These are up top is just the Medicare current criteria. So you need to basically, in your better ear, you need to understand less than 40% of the words that are said. In general, it's a relatively low risk surgery. This takes me about an hour to an hour and a half to do. It's outpatient. People do very well with this from a surgical recovery. Risk of facial nerve injury are, it should be a never event in this procedure. But you need a functioning cochlear nerve. And the problem is the tumor grows on the cochlear or grows near or pressing on the cochlear nerve. And so it's hard to predict how well people are going to do with this. And I have a set of people who have done marvelously with this, and I have a set of people who've gotten almost no benefit. And it's very hard to predict preoperatively who's going to do what. So a lot of groups, I'll talk just a little bit about kind of cochlear implants in general for people who don't know about them. They have an internal and an external device. What's nice about them is that they're actually powered through electromagnetism. So you don't actually have to, do a surgery to put a new battery in, anything like that. If you put this in, this should be with you for life. The external device is a microphone. It picks up sound. It has a signal processor that converts that sound to an electrical energy that then sends a signal down into a small electrode that we put in your inner ear. And because of that tonotopic mapping we talked about earlier, I can know that, hey, I'm going to make the electrode at the low frequency part fire when it hears a low frequency noise. And I'm going to make the part at the high frequency fire when I hear a high frequency noise. And they really, for the right patients, this can be a life-changing procedure. And then for patients without NF2, it's extremely, extremely helpful. There are 3 different companies that make them. They all work great. Lots of people freak out about which type they're going to get. They're all good. It's like buying a new car. They all have different bells and whistles. Whatever works for you is fine. This is just a little bit about the surgical technique. So I show the picture on the left, mostly show you, it's a very small incision. It's about 4 to 5 inches in size. It takes us, again, about an hour to do this. The procedure starts with just opening up the bone behind the ear. And just in the interest of time, because I thought I was going to be able to speed this up, I won't make you watch the whole thing, but basically you go down and you go between the facial nerve and the taste nerve. And most people who see that think, oh my God, you're so close to those nerves. But again, it's actually a very, very, very well tolerated surgery. And the risk of facial nerve weakness afterwards is less than 1%. Outcomes in this, I know this is hard to see from where you are, but if you can take anything from this, take it that they're wildly varied. Again, many patients do very well, but some do not. The best thing we have found for an indicator is how large is the tumor and how long have you been without hearing. The larger the tumor, the worse the outcome. The longer you've been without hearing, the worse the outcome. Some other people have found a few other in individual studies, things that might be relevant, but when I'm thinking about this, that's what I care about. But again, you need a cochlear nerve. And so if you've had surgery, it's hard to know unless you were the surgeon, did we save the cochlear nerve or not? And even if we've saved it, it's hard to know if it still works. And so there are a couple ways to do that. You can do something called Promontory Simulation, which is a little archaic, but can be somewhat helpful, where you stick an electrode into someone's ear through their eardrum and you actually stimulate the cochlea directly to see if you can pick up the signal. The problem with it is it's not perfectly predictable, or it's not a perfect predictor of outcome. So even if you have a poor outcome on this, I still wouldn't tell you can't get a cochlear implant because I don't know. And there's lots of studies that have shown people who have poor promontory stem still get a decent outcome, and people who have good promontory stem don't get a good outcome. The other thing to consider, and this is important to make sure that you have a good NF2 team that's kind of working together. The MRIs are all MRI compatible now. Or sorry, the cochlear implants are all MRI compatible now. And so it used to be an issue that we didn't do this because patients with NF2 need to get MRIs. Now we can get the MRIs, but it still causes a large shadow that you see at the top picture. And it's important to make sure that the neurologist or oncologist, whoever's caring primarily for all of the patient, is okay with the shadow that's caused. And that's a discussion we have very frequently. And something to be aware of. It is a thing that you can't really get rid of unless you take the magnet out. And finally, auditory brainstem implants. So this is for people who do not have cochlear nerves. And because you don't have the same tonotopic mapping, the outcomes are not as good. Most people get sound awareness with this. Very few get open set speech, meaning that they can hear something and without lip reading or anything like that can understand what it is. Most patients who have this report that it does help them in communication. But there is, again, very widely varied outcomes with this. And the reason why is because this picture on the top left, that's basically what we're looking at. And right about kind of here is supposed to be where the cochlear nucleus is. I think I'm a decent surgeon, but I can't tell you exactly where it is looking at this. And I can't tell you exactly where on that high frequency sound should be and where low frequency sound should be. So because we don't have that same tonotopic mapping, it's much harder for us to program these appropriately. But for patients who have no other options, this can be a good option. One of the other things you can see is just the electrode array is actually, instead of being a long electrode, we clearly know what's stimulating where. Here, it's almost like a patch that we put on, and we use over time testing with the patient to figure out, okay, which one should we make stimulate at which frequency to work for the patient. So the programming here is actually much harder than just programming a cochlear implant. So this is just a thing to show that there's just widely varied results with this, and that we do think implant positioning might affect outcomes, but that hasn't been fully worked out. So this is just a study looking at a group of patients with CIs versus ABIs and who seems to do better. And for patients who can get a CI, the speech outcomes are better. One of the things that has not really been discussed much in our literature, but I can say anecdotally, we see all the time, patients who have NF2 who get a CI and who do well initially. Over time, there is going to be some decrease in that for almost all patients. And that's, I think, important to discuss with the patient and to discuss and have an honest conversation that even if this helps you for a period of time, it might not in 5 years, but it might help you for a few years. And is that worth undergoing surgery? So I will pass it off to Dr. Blakeley, and thank you all so much for having me, and we'll answer some questions, I think, right at the very end. Oh, sorry about that.
Hi, everybody. I see a lot of friends here. It's wonderful to see you. I should get you to come up here and give this lecture because you certainly know as much as I do. Oh, nope, not working. Oh. Oh, but can I talk without slides? Yeah. So is that okay? Oh my God. That was from Dr. Creighton. Matt, I need your device to do is it working? I don't know. More of an impetus for me to learn ASL. I'm on the 20-year program. Yeah, we're good. It's not changing here. Oh, perfect. Okay, so the not just because I enjoy hearing myself talk, that's true also, but because I want to make sure everybody heard me, what I was saying is that really the people in this room should be giving this talk because through your own non-degree granting program, you have become the experts. But it is my honor to be here. What Dr. Sadke said is true. I am committed to research because I am committed to improving the outcomes for people who got stuck with conditions that they didn't ask for and that are beyond challenging. And yet the people who we are honored to partner with handle it with such grace and carry their own hardware to fix transcription problems like Matt Hay here. It's just remarkable. So ever inspiring, and thank you for having me. Maybe the most important thing I'm going to say is find yourself a multidisciplinary care team. Be a member of that multidisciplinary care team. Understand the pros and the cons. Understand that especially in NF2 schwannomatosis, There is no perfect right answer at any given time. It is always a series of what's best for this person at this time based on the tools available to us, and no absolutes. So every idea is a good idea until we decide that it's not right for now. So that's really, you can stop paying attention now, but I'm going to talk about some other things along the way. And I was able to witness how challenging it is to get your slides to advance. It seems like it shouldn't be. You just press advance. And yet, is there something I should point at? I'm clicking, my friend, I'm clicking. All right. So I am going to talk about a bunch of drugs that are off label because we do not have any drugs that are approved for NF2. And if you want to have a chat later about why Bevacizumab is not improved, there is a real reason. We had the opportunity and chose not to because we were afraid it would be the end of any research for NF2, and it's not the perfect drug. So we do have it listed in the NCCN guidelines, and having it listed in the NCCN guidelines lets us go to battle with insurance companies and win. But if there was an FDA approval, then we would not be working on new agents. So why does this matter? You heard a little bit about this already, but this is a real situation that happens all the time. A 17-year-old, healthy, doing great, who presents with hearing loss. 17-year-olds are not supposed to have hearing loss. And they come in and finally get their MRI, and you can see that on the right side where it says 70%, we like to do things backwards so that we can justify our clinical billing. So we make it seem really confusing. So 70% word recognition is pretty good. That's the side they're using for hearing. That tumor doesn't look great. That's a tumor that we might want to take out or do some treatment for. And the other side that you think, well, that must be the good side. That's the 10% word recognition score. So just back to what Dr. Creighton said, that size, actually, I feel in NF2, it's not only not correlated, sometimes it's opposite and really confounds the treatment decisions. And then when we finished the rest of the imaging, we found these other lesions. The one by the eyeball is a meningioma. There's another meningioma that's actually going to end up colliding with the vestibular schwannoma. That's going to complicate our treatment options. And then there are some spinal lesions. And why am I showing you this? I'm showing you this as an example of when someone says, okay, let's work on my hearing. At the same time, I'm keeping spinning all of the plates of everything else that's going on because I have to think about how that will influence the treatment decisions. And I took out only one part of the boring paper that Dr. Yohei presented to you to show you how complicated. I mean, I'm an author, so I get to call it boring, and it's boring, but it's really important. I don't know that it's so good that Dr. Yohei was able to present that today, because not only does it help us get closer to real treatments for each subtype of the molecular feature, which is, by the way, what we do for every cancer. If God forbid you've known someone with leukemia, we don't treat leukemia, we treat Philadelphia chromosome mutant leukemia with this specific chemotherapy. And so this move towards molecular specificity will improve our ability to treat specific conditions. But what I want you to know is it's important to get multidisciplinary care so we can pull out our little cheat sheet that CTF made for us because it is complicated. But these are the things that I want you to be thinking about when you're advocating for your own medical care. The reason chromosome 22 comes up is that NF2 and SMARCB1 and LZTR1 are all on that chromosome. It's a little bit like Jerusalem. Like, I don't know what your religion is, but probably it happened in Jerusalem, right? So chromosome 22 is where it's at, and we need to spend our time thinking about chromosome 22, and we'll figure out the specific sections separately. And another reason it matters to be thinking about genetic testing is there's pretty good evidence from our incredibly important contribution from our colleague, Dr. Evans, in Manchester, England, that the type of the mutation is associated with disease severity. And as we're looking at the chessboard of treatment decisions, we need to be keeping that in mind. It's working so great, you guys. Thank you. Okay, so how do people present? Why am I talking about hearing loss? Because most of the time people with NF2 present with hearing loss. That's the most common presentation, and it's usually someone who's in their late teens or 20s. Occasionally, people will present earlier than that, and that those are the people who present in pediatrics, and that's not hearing loss. There's usually something else going on, a focal nerve deficit, the foot that's not working, an eye that's not moving the right way. But hearing loss is going to be a part of it eventually. And these are the other tumor types that we keep in mind as I'm thinking about how am I going to address the hearing. The vestibular schwannoma is just one of multiple different cranial schwannomas. Fortunately, most cranial schwannomas don't cause problems, but sometimes they do. Like you have a schwannoma on the 7th cranial nerve, the facial nerve, that's a problem. That complicates everything we're doing with the 8th cranial nerve. Okay, so for NF2 schwannomatosis hearing loss, how do we think about this? There have been some very good natural history studies now, the last of which was completed in 2014. And basically, for the majority of people with NF2, the rare exceptions being people who have point mutations or people who have mosaic forms of NF2, not every cell has the variant in the NF2 gene, there's going to be hearing loss. The question is, when does that happen? But it's going to happen not when they're 70. It's going to happen when they're 20 or 30 or 40. And why does that suck? It's 100 reasons, but it sucks because if you lose hearing, if you're born without hearing, or you lose hearing when you're 5 or 8, you enter a school for people who are hearing impaired, and there is a rich and vibrant community that welcomes you, and you play lacrosse on the hearing impaired team. But if you lose hearing when you're 30, it's a lot harder to find that community. Not impossible, that's why you're here, that's awesome, but it's a lot harder. So this is one of the parts where the science meets with the social, and we have to merge those two things. So what you guys probably have all been through these. Why do we get audiograms? They are not a perfect science. Why do we get them? We get them because they tell us a pattern about the various places where you saw the anatomy that Dr. Creighton was speaking of. And let me tell you, I don't really understand this. I go to him with the audiograms and say like, okay, here's the audiogram, here's the MRI, here's what the person's feeling, let's put this together. But what we're looking at is the volume, that's the loudness part, that's what a hearing aid can fix. And we're looking at the clarity of sound. And they're complementary, but not always. So sometimes if you're trying to fix clarity and you make the sound too loud, you'll hurt the clarity. And I don't know if you guys remember in hearing tests, sometimes the audiologist will do something called a rollover test. So they'll give you the same test a couple different times at a couple different levels. And they're trying to find the level that is right for your ear on that day. Here's what stinks about hearing aids in NF2, that level that's right for your ear, it changes. So you might set your hearing aid on a Monday, and on Thursday it needs to be at a different level to maximize that clarity, which is why some of the cool technology, not inexpensive, but it lets you change it from your phone, what level of volume you should be at, because it changes like we change day to day. I am going to, could I ask someone over there, could you press one of these speakers for me? Like at the top, the speaker at the top next to the 90, could you press that please?
You will say and. You will say yard. You will say carve.
Okay. This is Scott Plotkin, a wonderful contributor and core thinker in the space of NF2, shared this slide with me. And I think for anybody who's living with NF2, you don't need to hear this slide, just don't pay attention. But if you don't, it was such an eye-opener to me for how frustrating it must be to have the hearing deficits where you can hear someone talking to you, that just the words make no sense. You can't distinguish them. So this is just saying it's an expression of when you go for a word recognition score test or a speech discrimination test, they repeat a bunch of monosyllabic words like ball or car or dog. And if the discrimination is poor, it doesn't matter how loud you make it, that just feels like more of nothing. And that's what this was showing you. But that's why we do those two sounds. We're looking for total appreciation at a certain level of sound, and then the ability to discriminate that sound. So I was talking about the mutation subtypes or the variant subtypes in the NF2 gene and how that can influence things. There are a couple other things that help us think about hearing. And so disease severity is one. The other is definitely the larger the tumor, the higher the risk, but it's not a one-to-one relationship as we were talking about. And one thing that we're better at recognizing now, and our neuroimaging has gotten better, is the more tumors there are. So sometimes you look at an MRI and it looks like one big tumor. But in NF2, it's never one big tumor. It's some number of smaller tumors. And that's one of the reasons why surgery is so complicated. It's also one of the reasons that the hearing loss can be so confounding, because if one of those smaller tumors is living inside one of the little tiny circles of the cochlea is about the size of the white part of my pinky fingernail right here, so pretty tiny. If there's a tumor in there, that just takes out the cochlea, and then you don't have hearing on that side, even if there's a teeny tiny tumor. So one of the things we're better at looking at now is we have a once a month case conference where we ask our neuroradiologist to help us look at the health of the cochlea. Okay, so someone calls me or they MyChart me and they say, I'm having hearing loss. What do I do about that? So first I want to say it's not always the tumor. It's probably the tumor, but it's not always the tumor. And there are a lot of things that can worsen a baseline hearing function that we can do something about. So the first thing I'll ask is about any other symptoms. Like, is someone having seasonal allergies, or did they just have a cold, or do they have nasal congestion? Is there something obstructive that I can fix that will restore to where they were before? And I can't tell you how frequently this happens. I want to say 3 times a week, I get a phone call or a MyChart about hearing loss. And it's something simple where we can address an inflammatory reaction. If that's not the answer, the next thing I want, or simultaneously, I want to see the person, have their ear evaluated, have them have the audiology, and see which portion has changed. Either way, if it's changed or not changed, I often ask for that to be repeated about a week later because the audiology is imperfect. I have one person I take care of who has downloaded an app for audiologic testing on her phone. And we've correlated that with when she comes in for official hearing test. It's awesome. Her test is excellent. So she now just uploads her phone readout of what her pure tone average and what her word recognition score is from her phone. And I get a pretty good sense of what's going on. If we've done all those things and there's still hearing loss, we use glucocorticoids. For this talk, I went to go find the evidence for this, and you will not be surprised to know that it's terrible. There have been 3 randomized controlled trials. That means people they had acute hearing loss. They did not have NF2. They just had acute hearing loss, and they were put on steroids or they were not put on steroids. And there was no difference getting steroids or not getting steroids in whether hearing recovered after there was acute hearing loss. But we do it anyway, because I think we all want that chance that it might get better. You want it and I want it, we all want it. And so in my practice, I limit that to a Solumedrol dose pack, which is a 5-day course, because I can limit how much damage I'm causing with glucocorticoids, which do cause damage. If you read the ENT literature, they say 10 to 14 days of dexamethasone or prednisone at pretty high doses. I'm going to just state the unpopular opinion. Dr. Creighton, please don't take this to your colleagues. The evidence says do not do that. And if you're on steroids for 14 days, then I have to wean you off for another 14 days. You definitely gained weight. I probably pushed your blood sugar up. And I didn't do you any help. So I'm going to stick with my Solumedrol dose pack, because although I have no evidence, it is better than having evidence that says to not do it and cause harm. So that's my hot take for today. And then while that's going on, I've already organized your MRI, and we're seeing if there's tumor growth, and we're seeing if there's change in the cochlea, because then I have to think about what other things we need to do for tumor. Okay, so my life's mission is to find and test and prove that drugs will prevent or treat the damage that is caused by tumors in people with NF1 or NF2 schwannomatosis, SMARCB1 schwannomatosis, or LZTR1 schwannomatosis, or schwannomatosis NOS. How about that, Caleb? Or NEC. Damn. All right. So close. And I practiced because I knew Caleb would be testing me. So these are the clinical trials that our community has performed for NF2 schwannomatosis. And when I highlighted in yellow, they had an endpoint that was focused on hearing, not always as the primary focus. All of the studies with Bevacizumab, that was the primary focus. For the other studies like everolimus, or the ongoing studies with selumetinib, crizotinib, and brigatinib, those are secondary endpoints. So that means we are testing it, but the whole study isn't designed statistically to test that endpoint. And why did that happen? That happened because Dr. Plotkin got frustrated that he didn't have options for his patients, and we used the drug bevacizumab in a tumor condition called glioblastoma, and we got pretty comfortable using it, and he said, well, why the hell not? Rather than just letting people not have any option. And he treated 31 people and they got better. So that was all retrospective, different doses, different settings. So then we did a prospective trial. Oh, and this was he also did some preclinical work to look at what all those worms are showing you up there, those green worms. Those are the little teeny tiny blood vessels that tumors rely on to grow. That term is called neovascularization. And for a tumor to grow, it has to make its own blood vessels. Avastin stops that neovascularization. So this is just an example of what Avastin is. It's a monoclonal antibody, a lot like the monoclonal antibodies that were created to treat acute COVID infections. They specifically target a protein. In this case, it targets this protein VEGF that you see there, and it will normalize the regular vasculature and take away the tumor vasculature, and will not allow the neovascularization to happen. So in this study, our primary objective was hearing. We specifically were looking for the proportion of patients who had an improvement in hearing in a measurement way that was statistically significant. So we wanted to prove that wasn't by chance, or it's true on Tuesday, but not on Thursday. And you can see the eligibility criteria, but specifically to enter the study, we had to be able to document that someone had progressive hearing loss, since that was the primary endpoint. And I already talked about the word recognition score, and here it is again, where we set a threshold. And the reason this matters is that this is an imperfect science, whether you're paying attention when the person reads you the word dog or not, or whether they are doing it in a consistent tone. So we wanted it to be very standardized, and we wanted to repeat any improvement at 3 months and prove that it was still there. This was the whole design of the study, where we treated every 3 weeks for a year, and then we stopped the drug to see how long it would keep its effect once you stop the drug. So this is what we saw. This is what's called a waterfall plot, and what you can see in the royal blue is those were the best responses. So for example, does this point? Oh yeah. So this person here went from a 20% word recognition to almost perfect word recognition. So that's a good day at the office. This person here, this is when we talk about a ceiling effect. They did get better, and they got statistically better, but they're just outside of the margin of error, and they can't get much, much better. So sometimes people will come in to see us, and they will have a word recognition score of 80% or 88%. And they'll say it's not normal, because it's not, they're right. But I'll say, I can't get you that much better. You're already up here. So don't take the risk of being on this drug when I can't get you that much better. But if you're down here, let's take a shot and see if I can get that better. And the rest of this is what it's showing you is all the blocks around it. That's the margin of error. And why am I showing you the margin of error? I'm showing you the margin of error because I want you to know how imperfect our studies are. So when we do a study from one time to the next time, this is how much error there is. So if I'm talking to someone and I'm not ready to jump on board with a new treatment, it's because I don't really believe the test result, because I know how much error is in there. And I want to see more data before I make a new decision. So what we ultimately showed is that 5 out of the 14 people met our criteria of a confirmed treatment response. That's not miraculous, but it is reliable and consistent. And it's a statistic I can use where I can say about 40% of people, not the majority, but about 40% of people will have hearing improvement if I treat them with bevacizumab. So I told you that we stopped the treatment, and what I really wanted to know is bevacizumab is a monoclonal antibody, like I mentioned. That means it doesn't get cleared out of your kidney or liver same day. It hangs around in your body for 6 or 8 or maybe 12 weeks. And I wanted to know how long we could hold that effect. And the answer is we can hold the effect pretty well till 3 months. Everybody kind of holds their effect, but we lose it at 6 months. Not everybody loses it. You can see this person, this is where they started. They drop off, they had to actually hold drug, they come back, but we start to lose that effect pretty reliably at 6 months. How do we use that information in real life? If someone has to stop the Avastin because they need surgery or because they own a yacht and they're going to go around the world for a year, I haven't had that one come up yet, but let's say, I can say you're going to hold your effect for 3 months pretty reliably, and after 3 months, you're going to start to feel the loss. And at 6 months, probably will feel the loss. This is showing the same data about the tumor size, the volume, and you won't be surprised to hear me say that there was not a relationship between if your tumor shrunk and how much it shrunk and if your hearing got better, which just highlights what Dr. Creighton was saying about how much more science we need to understand what is causing the hearing loss in NF2. It is not just tumor size. Okay. What about the safety of bevacizumab? It's not perfect. It's not terrible, and it's not perfect. The major risk we were worried about in 2012 was death. So I'm happy to say that doesn't happen, but we were scared to death of that, no pun intended, because bevacizumab carries with it a 1 to 3% risk of life-threatening complications. Perforation of your gut, that means, like, you know, where we put our Coca-Cola, that's not supposed to go in the sterile parts of your body. If that punctures, you have a very life-threatening condition. That happens in 1 to 3% of the population of people who take bevacizumab for cancers. There's a risk of blood clot, there's a risk of bleeding anywhere, including your brain or lungs or gut, scary things. And fortunately, we have not seen that in the NF2 community. And the really wonderful thing about the NF2 community is everybody talks. So we share these situations and we haven't seen that. What we do see is over time, there will be a general increase in blood pressure. It takes about a year to see it. And about 25% of patients on long-term bevacizumab had to either stop the drug or have drug holidays because the kidneys can't perform optimally. And that's because we're plucking off the blood vessels in the kidneys, like we're plucking off the blood vessels in the tumor. And when we do that, the kidney has little strokes. The kidney does not recover from those little strokes. It just lives on with lots of little strokes. But when you have enough of them, it can't keep living on. And so that's why we have to check the protein in the urine all the time. So what we learned from this experience is that bevacizumab 7.5 milligrams per kilogram, so it's dependent on the person's weight, resulted in hearing improvement that was sustainable and significant in 36% of people, and that could be sustained off of drug for 3 months and as long as 6 months. And even when we lost the 6 months response, it was better than baseline. There was no correlation between tumors getting smaller or not and hearing response, and there's cumulative toxicity with long-term use. The current studies that are happening right now are also testing hearing, but as a secondary endpoint. And so I just want to caution, we're not going to know as much. And the reason we're not going to know as much is the reason somebody gets enrolled, for example, in lapatinib or everolimus or crizotinib or selumetinib is because the tumor is getting bigger on MRI. You could enroll in that study and have perfect hearing. So if you have perfect hearing, I'm not going to learn a lot about what that drug did to address hearing loss, right? And that's going to be some proportion of those patients. They did test for everolimus there have been 2 studies, and in the people who had hearing loss going in, it did not stop the hearing loss. And the people who were stable going in, they stayed stable. So I'm not sure we're going to get a ton of information out of these studies about their impact on hearing in the short term, but we'll be able to contextualize it a little bit. But all of these studies are designed to say, do they shrink tumor? And brigatinib in particular is for any NF2 tumor. So vestibular schwannomas, the other cranial nerve schwannomas, meningiomas, etc. Okay, so this is my last slide. And really, who knows what this is? Well done. Who knew that? I mean, but we're like the same age, dude. So that's like, all right. So what I'm referencing is Build a Better Mousetrap, but I actually have this game and it's a lot of fun. So and the thing is that we are constantly with everybody here trying to build a better mousetrap. We need to know more about the proteins that are in the fluid that is bathing the vestibular nerve. We need to know more about how we can make the cochlea more resistant to schwannomas. We need to be preventing schwannomas in the first place. That's what all of this gene therapy excitement is about, is if you could fix that up front, you'd never get to that position. Unfortunately, that is unlikely to fix once there's already a tumor there. So we have to continue the other part. That's that's why there's so many pieces here. We have to treat what's there now as well and do that in a smarter way without using cannons that can cause more harm than good. And I just want to advocate for, again, the multi-specialty collaboration. These are hard problems and we need teams that are coming together thoughtfully to try to solve them, including the person who lives with the consequences of those decisions. And we definitely need much more basic science. I'm a clinical scientist. Do not put a pipette in my hand. Don't ask me to run a Western blot. It will not go well. But if we don't have better understanding of the science underlying the schwannomas that are causing this damage in the first place, we're not going to have more clinical trials to run. So with that, I will say thank you for having me. Thank you for being our partners, for all the advocacy that you do, for all the good ideas that you bring forward, and for just being awesome. Thank you. So Pete, you want to come up? Yeah, so Dr. Creighton and I are going to take questions together, because if you ask me a surgical question, I'm going to turn right to him. Yes. Yeah, just use this.
So I don't know if this is allowed, but I'm on year 19 with my ABI, and expectation management was probably the best thing my audiologist did for me. But the flip side of that is I had a lot of people tell me what I would be able to do with it. And after about 5 years of trying, I got about where they said, this is what you should be able to do if all goes well. And I quit trying. And my hearing did not get better with my ABI for another decade until I had kids and decided I'm not happy enough with this. I'm going to keep trying again. And I improved with my ABI on the sample size of one. The data that shares is not a sample size of one, you would probably get fired. So this is just my experience. This isn't a Alexion. This is a pop in. This is just my experience. Is that getting over the notion of letting someone else tell me what my brain is capable of doing with an ABI, when there really aren't that many. I think held up what I was able to do.
Thank you. My name is Ken. I have NF2, and I was, I think, okay, I was diagnosed 40 years ago. So then I had my surgery. My left side completely deaf because they cut the auditory nerve. Right side, I got back a little of my hearing. Oh, 5 years ago, I about a Cochlear thing. And now you may be able to get one because it's pretty stable. It's not great, but it's stable. It hasn't changed. And the Cochlear implant comes flexible. So I signed up. I got one, and it's a lot better than my hearing aid. But I'm not getting like 95% of and I was told that's because of the damage to the auditory nerve. So a couple of questions. When you said being able to get a cochlear implant depends on a working cochlear nerve, I think you mean auditory nerve, right?
Yeah, we think of them as the same. It's kind of like saying acoustic neuroma and vestibular schwannoma. They're the same thing. Typically what we say is the acoustic nerve is the 8th cranial nerve, and it has both a branch that is the vestibular portion, and then it has a branch that's the acoustic portion.
Okay. The other thing was that you said after about 5 years or a few years, it drops down. So I should expect my cochlear implant to degrade, or how much I can hear and comprehend.
It's very individualized per patient. The fact that your hearing had been stable for a period of time does likely indicate that that nerve is stable. And it's very variable. I've seen patients who have gone, 7, 8 years without any change, and other patients who were great for a year and then started dropping. And I think that's one of the things that's really hard is like, I'm a surgeon. I like exact science. That's how I'm programmed to think. And everything in NF2 is not exact. We know basics, but being able to give really good predictors of outcome is really hard.
Okay, thank you.
But I also will say, I think the point that you say where you've been thinking about it for 30 years and everyone was like, no. I think that paradigm is changing a little bit. I hate to admit this, but I think part of it is changing because now we can get them paid for. And it's silly that held things up for so long, but that has been a big change for us, and I think made it much more possible for patients to investigate that as an option recently.